Andrew, thank you for the introduction. And I just want to say that I'm privileged to work with everyone who's presented thus far today, as well as, you know, many people who are listening today also. Everyone who has been working so hard to advance the care, as well as looking into, the treatment and the pathogenesis of the diseases that affect children here with myositis. So um, these are the topics that I'll speak about in today's presentation. I hope to get to the final item, the challenges, in a timely manner, as I believe this includes issues that are of considerable importance as we move forward in our efforts at collaboration. So I hope that we can get there. Um, at various times with this biorepository that we have, I've thought about whether we should be calling it a biobank or a biorepository, but I wasn't really losing much sleep about it. So until preparing for this presentation, I'd not looked into definitions, as I assumed the terms were essentially interchangeable. So when I did search for definitions, I really didn't find any strict distinction, and most explanations did consider them fairly synonymous. However, in an interview with Dr. Andrew Brooks at the 2019 Bio-IT World Conference in Boston, Dr. Brooks stated that he considered the following as distinguishing features between a biobank and a biorepository. When I think about the working definition of a biobank, I look at that as a focused program that has defined endpoints in mind for a defined community, whereas a biorepository is a program that is looking at a more global, collaborative standpoint with a wider variety of biomaterials with an eye on collaboration now and in the future. I'll reflect back on this quote a little bit later in the presentation. After we had established a dedicated myositis clinic, we decided that we would start a specimen biobank for translational research. There were many details that needed to be considered and addressed in the process of establishing our first biobank. First, our purpose was to establish a reliable and high-quality data and biological specimen repository to collect and store specimens from children with JDM as well as healthy controls. Secondly, we needed to identify the infrastructure, as this was going to be a small biobank just starting out. We only needed a lab space equipped for processing and storing samples. We found what we needed in a colleague's immunology lab space. We also needed to set up a secure system for collecting and storing patient clinical data. We decided that we would collect blood to be processed for plasma, serum, PBMCs, and RNA. When available, we would also collect muscle to be stored by pathology. Once we finalized our protocol and identified our facilities, we wrote the IRB and consents. At the beginning, we considered our biobank to be basically a single institution, disease-based translational biobank. We collect samples at enrollment, 3, 6, 12, 18, and 24 months, then annually until year 10. And we also collect samples with disease flares. Parents and patients are asked to complete outcome measures at study visits. Physicians and physical therapists also complete measures related to disease activity as well as damage. And some of these measures were included in Susan's dashboard. Oops, sorry. When the opportunity arises, we also obtain skeletal muscle biopsy tissue to be frozen and stored. This is tissue that remains after pathology takes what's required for their studies. Our first whole blood sample was processed on March 11th, 2016, and our first paired blood and skeletal muscle biopsy sample was obtained on August 15th, 2016. This bar graph shows the number of aliquots, biosamples that we have collected from 2016 to 2022. So for example, in 2016, from 34 separate blood draws, we banked 919 aliquots, comprising 34 samples of RNA. I lost my arrow. And 421 serum samples. There goes my arrow again. In the green, 360 aliquots of plasma, and in light blue, 104. And in the light blue, 104 aliquots of PBMCs. As you see, COVID affected our collections in 2020 and 2021, from which we recovered in 2022. Our initial translational projects have included a biomarker study utilizing metabolomics analysis of patients prior to and after treatment, and a second study looking at differential gene expression between treatment responders and non-responders. These studies were supported by CureJM as well as CARA, and both studies are published. And the bibliography will be at the end of the talk. In 2022, we elected to move our biobank to a larger facility due to the anticipated growth of our sample collection as well as the lower cost of the facility, a large biorepository at the Duke Human Vaccine Institute. This unit is a core resource available to Duke researchers on a fee-for-service basis with protocols for storing biological samples isolated from human and non-human primates. It recently completed review for ISO 2387 biobanking accreditation, which I'm told is an important accreditation to obtain. And in 2021, it processed over 75,000 samples. The unit charge is $230 to process a single patient sample for storage. The storage cost is $6.62 per month. So to process whole blood into plasma, serum, cells, and to store the PAX gene tube, as well as all the aliquots. So this, going back to the quote, so in considering, again, biorepository, biobank, I don't know if it matters whether we call what we currently have a biobank or a biorepository. But when I again consider Dr. Brooks' words, I believe that we've embraced the philosophy of collaboration outside of our institution, and we're opening up the biorepository to a wider variety of biomaterials, and we've developed a plan to sustain it into the future. So in essence, we're meeting the sentiment that he expressed for a biorepository. And collaboration in his mind was one of the key features of a biorepository. And we intend to continue to do that. We're open to collaborations. As you saw, we have a significant amount of samples, including a large number of longitudinal samples. And we are contributing to the both of Dr. Turnier's current studies. I wanted to get to this slide to discuss some of the challenges of maintaining a biorepository. Some of these are personal challenges that I've encountered, but some of them are challenges that I think we have to consider again as we do collaborate. And one of the major ones is harmonization across biorepositories, because as I just stated, we have a large number of samples, and in order to utilize those samples, it's best that they're being used in a manner where they're being compared to other samples in other sites that have been prepared similarly. And in the future, harmonizing what we do in processing, will help to guarantee that future specimens are used maximally. So that's one of the areas I think that's important for future discussion as we collaborate. Another area that is important, and Dr. Turnier brought this up also, but it's being, I think, discussed through, again, the CZI initiative with our focus group through CureJM, where we are asking our family group to address the approach that we take as individuals interested in research, when we ask them to consent for biorepositories, for research, how we do that, how we approach them. And some of the things I think we all consider when we're doing that is the timing of making that request, right? We're doing it at a time when we're also likely giving a family a diagnosis, a time, when we're considering what we're going to do in treating them. We're all very interested in getting that treatment naive sample because that's a precious sample, but it's also a very stressful time for the family. How much do we ask when we ask for those samples, and what specimens, do we ask for? So just the ethics of that, or just the approach to that's important. And then my final point here, I guess, is, we have these institutional biorepositories. How are we interacting with the biorepositories that are more centralized, like the Cara biorepository? How is that relationship going to develop over time? How are we maintaining both of those? Does it make sense to maintain both? Another important discussion I think that we need to have moving forward. So there are just some points that I think are important. And those are the ones that I see just that would affect all of us as we think about biorepositories. Additional ones are the costs of maintaining a biorepository, how you do that. We have a specific grant that will come into fruition in a year or two, where we will be able to sustain our biorepository off the interest of the grant as it matures. So that's one way that we've been fortunate to be able to do that. Up until that point, CureJM has been helping to sustain our repository. I hope they know that. If they don't, I may be in trouble. But so those are some of the things that I think about just from a challenge perspective. These are some of the completed grants and papers that have come from our biorepository. Some of the current grants that are out there that are using samples from our biorepository. And these are some of our acknowledgements, and there's many other people that are out there that are involved. So I will stop now. Thank you all for listening. I appreciate it.
Thanks, Jeff, and we'll open it up to questions now. I know from a foundation perspective that we appreciate the value of these biorepositories with such a rare disease, and as Dr. Tournier pointed out, the access to these samples can be invaluable in not just kickstarting new research initiatives, but to really add depth to some of these research studies, and having diversity in these biorepositories we see is really important. And I think you bring up a really interesting point, which is once you start these biorepositories, it's one thing to actually collect the samples, but long term they have to be maintained, and how does the funding occur to actually maintain these biorepositories? Because it's not like you can just turn the light off at the end of the day. The samples then become useless, you've spent so much time and effort collating and curating. But yeah, the foundation appreciates getting access to different research groups of these biorepositories. And I don't know if there are any questions popping up on the chat board.
Yeah, I do think that moving forward that maybe, we could have some discussion about some of those points, and I'd just be interested in knowing what other people think about some of those discussion points, and I'm sure we'll learn some of that, especially again as we get the input from the CZI group and everything too.
And obviously, as there's so much local knowledge that ends up being captured along with these registry and biorepository samples. And I think that's where what Dr. Kim was saying from California is, having, that epic tracker, having that sort of thing. And if we can try and integrate and have one sort of platform, which I know we're trying to do with the Cara biorepository, so it would make interrogating these sample sets so much easier for research groups. But yeah, it would be invaluable to figure out the best pathway forwards to actually do that in the future.
Yeah, well, I agree. Thank you.
If there are no questions, I'm now going to hand it over to the CureJM Executive Director, Jim Minow, to make some closing comments on what's been a fantastic session. So thank all the presenters. Jim.
Great. Can folks hear me now? Jeff, I think you're still sharing your screen. Great. Well, I want to thank everybody for your participation in today's a really terrific symposium for our clinical care network, sponsored by our clinical care network. CureJM is completely and all in, as I guess the best way to say it, into the expansion and development of our clinical care network. Our goal and our role, as we begin to see it, is to expand services so every child with JM in the United States, no matter where they live, no matter how far they may live from excellent service, has access to that excellent service. Recently, we've been able, through our clinical care network, to expand to some 27 locations around the country. That's I think, a significant growth over the last couple of years. We're committed to continuing that expansion to areas of the country where we do not have great access, when I say we don't have great access, what I really mean by that is that CureJM perhaps doesn't have the strongest relationships with pediatric rheumatology departments as we would like to have. Those are both supportive relationships, financial relationships, and partnerships with our families who live in those areas, with a focus on improving access, improving quality of care, and assuring that every JM child has reasonable access to that care. We're committed to doing that. We're committed to raising the money to fund that, and really want to thank our presenters today. Really look forward to continuing to develop programs like these for all of you in the pediatric rheumatology world. Really looking forward to our expansion of fellowships, looking forward to our expansion of training programs for pediatric rheumatologists who are interested in learning more about how to provide the best quality care to JM children around the country. So thank you for being with us. I want to thank all of our presenters. I want to thank Andrew for putting this together, and look forward to our continuing discussions together. We'll be seeing some of you, I think, at the upcoming GCOM conference in Pittsburgh in March, and online with the upcoming CARA conference that I think is taking place in April or a little bit thereafter. So thank you. If any of you have any questions about ongoing engagement with CureJM, with the Clinical Care Network, please feel free to reach out to Andrew or to me. Thanks for being with us, and look forward to talking to all of you soon.